Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, newly returned from my vacation in Costa Rica.
How was Costa Rica?
Costa Rica was awesome. Costa Rica is a treat. Costa Rica, everybody in the world should have the chance to visit this amazing country with its ecotourism and animals and birds and wonderful people.
We included a plug for the Costa Rican tourism
agency
here. It is amazing, though.
It was great.
We'll try not to just dork out on birds for the rest of the time.
Well, you need to know that I now carry binoculars around wherever I go.
Okay, so keep an eye out for Lisa Dixon at the next conference with the binoculars.
With my binoculars, yeah. Actually, that's not true. I'm really not a good bird watcher. Anyway, I happen to be the editor of Psychiatric Services, and I'm here with our podcast editor and my co-host, Josh Berezin.
Hi,
Josh.
Lisa.
All right, Lisa, get on script. All right. Today, we're going to talk about 3 articles from the journal that have recently been published online. We're going to take an inside look at an article on a lifestyle intervention, scaling up a lifestyle intervention. Second, we're going to be talking about the results of a peer mentor intervention for persons with recurrent psychiatric hospitalizations. And then we're going to conclude highlighting a new feature viewpoint article that's going to focus on timely controversial issues. And the inaugural viewpoint column written by Richard Frank and Sherry Gleed is going to focus on the potential for work requirements to get Medicaid.
A hot topic.
It is a hot topic, and it's a really good piece, and I'm very excited to have this new feature of Psychiatric Services.
So first up, we have Stephen Bartels and Mary Brunette on the implementation of a lifestyle intervention for people with serious mental illness in state-funded mental health centers.
So Josh, I just want everybody, all our listeners, to know that there are more than 2 authors of this paper, and I have given up on the idea of listing every author because there are simply too many. So you win.
Berezin 1, Dixon 0.
That's the score for today.
That's today's score.
I don't want any of our listeners to think that we don't appreciate the contributions of all the authors. It's just that we don't have the time to go over every single person. So 3, hats off to the authors, but we're only going to mention, moving forward, the first and the last, excuse me.
Yes.
What is this paper about?
This paper is about an important topic that we've talked about a number of times, which is this big health disparity among people with serious mental illness with their shortened life expectancy compared to people without a serious mental illness.
Right. And of course, we know that one of the important causes of that disparity is obesity, also smoking, and perhaps other quality of care issues. But obesity and physical fitness are really problematic among people with serious mental illness.
Right, and there have been randomized controlled trials that have looked to address those particular issues to kind of try and get at these this disparity in mortality, to address specifically obesity and fitness.
Right, yeah, so we're getting some traction in the area of identifying and specifying effective interventions. And this study focuses on one of those, InShape.
Right. And so there's this intervention called InShape that has been tested in a number of randomized controlled trials. So it's sort of like on the shelf, right? And this study is about how do we take it from the shelf and get it into the community.
Right.
And in particular, the State Mental Health Authority in New Hampshire wanted to see if they could implement InShape in a number of their community mental health centers, and to look at both if it maintained its effectiveness, but also how it rolled out.
Exactly. So if we think about this kind of a study, this is a study that's testing the scaling up of an effective intervention. So in this kind of study, we have to think about sort of 2 interventions. We have the actual intervention that's being deployed or rolled out. In this case, it's InShape. And then the other intervention that we have to think about is how this InShape program is being scaled.
So why don't we start off with what InShape actually is? So this is centered around weekly meetings with health mentors. These are certified fitness instructors who undergo a special training to work with people with SMI. They meet for about an hour with a client at a gym every week and go over fitness and nutrition.
Okay, so we have this intervention. How are we going to take this intervention and put it into practice on a bigger scale? So the first thing that happened was the state had to have a discussion and make a commitment to it. So state leadership met with investigators and they said, okay, we want to do this. And in the context of their saying they had to do it, the next thing that had to happen is they had to take all the materials for the intervention, which were built for researchers, and translate them into materials that could be used by regular old practitioners in the community. So that was the first thing they did. Then the second thing that they had to do was to look at their mental health centers, and there were 10, and they want to deploy this at 10 mental health centers, and figure out who's going to go first, because they figured they would do this over 5 years. And so they did a series of assessments with the leadership at the mental health centers to determine the readiness and the fit for this intervention at the various agencies. They identified 4 of the 10 agencies which would be in the first batch.
And so two of those 4 agreed to delay their start by 12 months.
Or 2 agreed to go first.
Glass half full, glass half empty.
Right. And so they had these 4 agencies. 2 were going to start and 2 were going to follow. And it is important to note that this was not, that who started and who followed was not done by randomization.
Right. So they ended up looking at 63 people in the 2 intervention sites compared to 59 in the 2 control sites. Mm-hmm. And they found significantly greater weight loss at a big effect size of 0.89 for weight loss at the intervention sites. They also found reduction in BMI, improved measures of fitness, and also improved reports of readiness to engage in physical activity. So actually 60% of the InShape participants achieved clinically significant reduction in cardiovascular risk factors. This wasn't significantly different between the intervention and the control sites, but it was consistent with what they had found in their previous study.
Exactly.
And so that brings up my phrase of the day, which is voltage drop.
Yeah, voltage drop. Voltage drop is the bane of implementation researchers, and what it means is when we say voltage drop, we mean the frequently observed reduction in effectiveness of an intervention as it goes from being tested in the research setting to usual practice.
What happens between those two, the ivory tower and the day-to-day?
Well, maybe first of all, we have a less specified and narrow population of people to whom the intervention is being offered or it's being tested. We have regular clinicians in regular practice who don't necessarily have all the training and the reminders and all the motivation to perform the research intervention in the way, maybe in its most perfect way. Mm-hmm. And you have people who are busy with a million other things, and this particular intervention isn't necessarily the only thing on their hit parade. So we see voltage drop. What's interesting is that in this study, there may not have been a real voltage drop, but particularly since it looks like the percentage of people who experience the clinically significant cardiovascular risk reduction is about the same in the RCTs as it was in this study, even though it wasn't statistically significantly different from control in here.
What do you think people can take from reading this sort of study about the implementation of programs?
I think that this is a really important study because it provides a roadmap for how one state worked to implement a really important evidence-based practice in their usual care settings.
Next up, we have Maria O'Connell and Larry Davidson and co-authors on outcomes of a peer mentor intervention for persons with recurrent psychiatric hospitalizations. We seem to be coming back to peers pretty often, I think highlighting the importance of of peers in our public mental health system.
Yeah, and also I think an increasing focus on trying to develop the science.
Right, right. And then the other kind of big piece of that's important is starting to look at high utilizers, particularly of inpatient services in this setting.
Right. And of course, why look at high utilizers? One reason is because clearly we're not serving them well, and the other is that they cost a lot.
Right. So there's this specific subpopulation that we're not doing that great of a job with.
Right. And so this particular study is looking even at a further subsample of those individuals who are readmitted, right?
Right. And there is some evidence to support the idea that peers can help with these clients. And actually, the authors have already published on their randomized control trial showing that for a group of patients with multiple psychiatric hospitalizations, peer mentorship program was associated with reduced hospitalization. And this paper is drilling down into some clinical outcomes and also community tenure. So this is a randomized control trial that was done at Yale New Haven, recruited from a group of people with serious mental illness who had had either 3 or more admissions to a psychiatric inpatient unit over the past 18 months, or they had had a second admission after, I think, 3 ED visits over the past 18 months.
So we're not just looking at high utilizers, we're looking at super high utilizers.
These are the so-called like revolving door clients and patients. So those who met this very specific criteria were randomly assigned to either...
Well, first they had to consent.
Right.
They had to
consent. That whole consent thing. So we'll get back to that in a few minutes when we get to their findings. Yes, consent is important. Those who consented were randomly assigned to standard care or standard care plus a recovery mentor. And these are, I think they had a group of 8 peers who had undergone what sounds like a pretty rigorous training in recovery-oriented peer services.
Yeah, and I think another interesting dimension to this peer intervention was that these recovery mentors worked independently from the usual services that the individuals in the study were to receive. So they would get their usual care, wherever they were going to get upon discharge, and then these recovery mentors were added on, but independent of the treatment system. And the intervention lasted 9 months.
9 months, and the peers got a lot of training, ongoing training, supervision and support throughout those 9 months.
Right, right.
So they worked together for 9 months, and they were encouraged to meet at least weekly. But they, again, since it's a recovery-based intervention, they're meeting based on what the sort of pair comes up with as appropriate.
Right, exactly.
Okay, so back to the consent. They found that as they're doing this study, there were about 4,400 people who were admitted to the inpatient unit over, I think, a 2-year period. Of those, 300 met those inclusion criteria that we were talking about. And I think it's important just to reiterate that this is a very high utilizer subgroup.
Right. So 300 out of 4,400.
Right. And so of that 300, 93 consented and were then randomized. Right.
So again, it's of interest and perhaps of some concern that about a third of the individuals who are eligible consented.
Right, and we don't necessarily know what that means, right? Yeah. Are they not interested? Is it part of the difficulties in timing of getting a research study done in an inpatient unit when people are moving in and out?
Exactly.
Hard to know. Yeah. But so 93 consented and were randomized. 15 withdrew. 2 people died. So then you have 76 people who are in an intent to treat analysis.
Right. So we're down to 76 people.
And we're going to go down a few more. So a little less than half, about 44% of those who were assigned to the recovery mentor didn't participate.
Or they didn't meet with the recovery mentor.
They didn't meet with the recovery mentor. Right. That's right. So that leaves 51 total people, 22 in the mentor group and 29 in the just standard care group, who are considered to have engaged in treatment.
Yeah, although it is important to note that, we're going to be presenting intent to treat results. So the issue of who participated and who didn't is of interest in terms of understanding the deployment of the intervention.
When they look at their sample, clients were on average 40 years old, equally divided by gender. About 75% had a psychotic disorder diagnosis, and about 25% were diagnosed with a mood disorder. So one of the important findings here is that the mentorship group had a median length of 270 days before their next admission, compared to 135 days in the standard care group.
So the standard care group was essentially admitted more quickly.
Right, or the mentorship group were out of the hospital for longer.
Exactly, yeah.
Yeah. And just to put another way, 9 months, 2/3 of the standard care group had a psychiatric readmission, compared to just under half of those who were in the mentorship group.
And I think this looked like it was just shy of statistical significance.
Right. So they also analyzed a number of outcomes on substance use, symptoms, functioning, and other measures of recovery. And they found that the mentorship group had improvements on measures of drug use, physical health, self-care, and unusual behaviors and excitement.
Yeah, as measured by the BPRS scale. So I think the investigators also reported the differences between the individuals who received intervention, but we will let you look at the paper to get into that level of detail.
No spoilers here.
No spoilers. We do not report spoilers. Why is this important?
Well, I was just about to ask you that.
Okay, well, I really like to answer that question, so I'm going to. I think this study is important because of what it teaches us and the questions it leaves unanswered. So what does it teach us? Again, it was a well-done study. It does show that having these recovery-oriented peers, can be helpful. There's a hint that it's helpful in increasing community tenure and improving a range of symptoms and substance use. And again, when we have it's a good, well-done, scientifically rigorous study. But then it also leaves us with a number of unanswered questions.
Yeah, I mean, one thing that comes up for me is what was going on in, if you look at the consort diagram at each step of the way, where people either aren't consenting to the intervention to begin
so only
with.
About 1/3 of the people who could consented.
Right, and then some people are gonna withdraw their consent or die. But then even with that remaining population, not all of them, and a significant proportion of them, didn't engage with the peer, the recovery mentor, and that's a big question that this raises for me: is what is going on there? Are these the same reasons why they're not? Why they're coming back to the hospital? Is that the same reasons why they're not wanting to engage with a recovery mentor?
Right.
That's not necessarily a criticism of the study, but it does bring up a lot of interesting questions about how to engage this sort of by definition challenging to engage population.
Right. And I think it also raises questions for me about the fact that the peers in this study were not connected to treatment teams in a direct way. They were independent. And so might there be some individuals for whom that connection is important, and maybe for others it isn't. But how did that figure in to the findings?
Or for others, maybe it's specifically important that they're not connected to their treatment team. So it's a lot of different.
Yeah. And I think it is important for us to mention that the study is a little bit limited by the fact that there were multiple statistical tests done, and there was no correction for multiple tests. So in some ways, the whole study, we have to think about the whole study, as the authors say, as exploratory. But at the same time, it does it moves the dial a little bit forward in terms of the power of peer-based services.
Step by step. So last up, we have Richard Frank and Sherry Gleed on work requirements and Medicaid for people with mental illnesses and substance use disorders. And this is a viewpoint.
Yes, thanks for throwing me that question. It is a new feature for psychiatric services. we're going to be featuring short essays, 1,200 words or less, on important controversial issues of the day. We'll be getting opinion leaders, as you can see here, Richard Frank and Sherry Gleed, writing on these topics, trying to get these pieces out quickly and establish a perspective for all of our readers to relate to respond to, and help guide their understanding of current events.
And this is a great one to kick it off.
Yeah, very pleased with it.
Yeah, so they're writing about Medicaid work requirements, which have been in the news recently. Kentucky has secured a waiver for Medicaid work requirements, and 10 states are in the process of doing so right now.
Yeah, so securing a waiver means securing the possibility of denying Medicaid to people who are not working.
Right, so people wouldn't be able to have their Medicaid benefits unless they meet a particular work requirement.
Right, so that's what getting this waiver means.
Right, and so this viewpoint is really asking us to think through how these work requirements would potentially affect people with mental illness and substance use disorder, which is a big chunk of the Medicaid population. So about a third of adult Medicaid beneficiaries have a mental illness or substance use disorder.
That requires treatment, I might add.
Yes. So it's important to say that probably the work requirements aren't going to apply to those who get Medicaid because of SSI.
Or who qualify for Medicaid, right, based on having Social Security and being adjudicated as being disabled.
That's right.
Right.
So that still leaves half of this big population who would be subject to these work requirements. And this paper is really outlines how this might play out for that population, particularly who's going to qualify for exemptions, right? So one of them is medical frailty. If somebody presumably is too medically frail to work, they would have an exemption from work requirements.
Yeah, I had never heard of this notion of medical frailty before as a consideration, but I think it's the paper then says, well, will this consideration of medical frailty protect people with mental illness and substance use disorders who don't have SSI and would thus be would lose Medicaid? Because if they're just considered medically frail, then they'll be able to keep their Medicaid. So that's a question that they ask. Right,
and they outline a couple of barriers that makes them and probably would make the reader skeptical of whether or not these exemptions would be adequate. So one of them is that the determination process already for like disability is inconsistent and has a lot of errors in it. So it's likely that
this costly and burdensome.
Right. And then also this population has a lot of medical comorbidities, so that complicates the medical frailty question. Disabilities are intermittent in this population, right? Somebody might have a 6 weeks episode where they can't work and then be fine to work right afterwards. It's all very complicated, and as you're mentioning, will probably lead to a big administrative burden, but that burden's not just going to fall on states.
Yeah, well, and then the other part of the problem, as Frank and Gleed outline, is that the pursuit of a medical frailty determination really then rests on the individual who, him or herself, has impairments due to their mental illness and substance use. So all of these factors lead to the somewhat inescapable conclusion, I think, that a whole group of people who desperately need treatment, who get treatment by virtue of having coverage with Medicaid, might lose that access to treatment.
And then sort of paradoxically, from the sort of proposed point of the program, that actually might make them less likely to be able to participate in the labor market.
Right. Yeah, as the last sentence of the essay reads, access to treatment, not denial of treatment, promotes labor market participation for people with mental illnesses and substance use disorders.
Yeah, so we really encourage everybody to read. There's more sentences like that. It's really good. It's short. It's easy to read, and it also gets you up to speed on an important policy issue that's in the news right now. Right. It's really good.
And you know what? If you disagree with it or you have an alternative viewpoint, we want to hear from you.
To be continued.
To be continued. So that concludes our podcast for today. It was fun. I think I'm never going to go on vacation again because I don't want to miss doing a podcast. And I should say I am very, very grateful to Dr. Lloyd Sederer for covering for me. And I think we're going to have Dr. Sederer back if he's willing.
Stay tuned.
Yeah. So we invite you to visit our website, ps.psychiatryonline.org, to read the articles we discussed in this episode as well as other great content. We also welcome your feedback. Please email us at psjournal@psych.org, and you can also rate and review the podcast on iTunes, Stitcher, or whatever you listen to. I'm Lisa Dixon.
And I'm Josh Berzin.
Thank you for listening. We'll talk to you next time.